Good afternoon, everyone. Today we'll be looking at critical appraisal of a non-inferiority trial. As Sir had already explained, normally in a randomized control trial, most of the studies are superiority trials, where we are trying to prove this is the point estimate, this is the confidence interval, this is the lower limit of the confidence interval, this is the upper limit. This is the line of equity or line of nil significance. So, in a superiority trial, we're trying to prove that the point estimate is favoring your intervention group, and the confidence interval does not cross your line of equity. So, the other studies that can be done in a randomized control trial are equivalence trials, where you're trying to prove your treatment drug is as good as your control drug. So for this, prior to doing this, first thing before we start the study is to determine your margin of equivalence. So this is done both by the clinician and the statistician based on previous outcomes and clinical experience. So they have to determine this line of margin of equivalence before starting the study, and then after they do the study, they determine the point estimate and the confidence interval. So in these studies, the confidence interval lies between your margin of equivalence. The other study that we discussed is a non-inferiority trial, where also you have to determine your margin of non-inferiority. That is also done before the study is being started, and it is done done by the clinician, determined by the clinician based on the previous studies. So here we prove that though your point estimate is still favoring your intervention group, but the lower limit of your the upper limit of your confidence interval crosses your line of equity, but it still does not cross the line of your margin of non-inferiority. So as we go into the study, we'll understand it a little better. So I want to start with the clinical scenario. Here we have a 42-year-old lady, Mrs. V, who has completed her family. She's been recently diagnosed to have early stage carcinoma cervix. So she was advised radical hysterectomy followed by radiotherapy if required by the physicians. The patient's aunt was recently diagnosed with CS cervix about 10 years ago, and she underwent radical hysterectomy with chemoradiotherapy following that. However, following the surgery, she noted that her aunt had a poor quality of life. So she saw that her aunt had urinary incontinence, intermittent pelvic pain, and her quality of life was overall poor. So she's inquiring that if there's any other options for surgery available with lesser side effects and with a better quality of care. So what would we advise her? So address this question. This is an article on simple versus radical hysterectomy in women with lower risk cervical cancer. It was published in NEGM recently in February. So we will be critically appraising this paper with the CAS checklist. So the first question is, did the study address a clearly focused research question? To answer this question, we want to look at the PCOT statement. The population that the study included were patients with carcinoma cervix with a FIGO stage 1A or 1A2 or 1B1. So it is a lower stage carcinoma cervix with lesions not more than 2 centimeters. The intervention here, so ideally the standard of care for these patients is, as of now, is radical hysterectomy with pelvic node dissection. So we are going to compare it with our intervention, which is a simple hysterectomy with a pelvic node dissection. The outcome that we are measuring is cancer recurrence in the pelvic area. So pelvic cancer recurrence is what we are assessing at the end of 3 years from randomization. Inclusion criteria. So the patients that they have included are patients with squamous adenocarcinoma and adenosquamous carcinoma of the cervix. Main thing is they have included only FIGO stage 1A2 and 1B. Lesions not measuring more than 2 centimeters with a limited cervical stromal involvement. So less than 10 mm in the initial diagnostic procedure, or in an MRI less than 50% involvement of the stroma. They have included tumors of any histological grade, and there should not be any evidence of lymph node metastasis. So they have excluded patients with other histological subtypes, patients with lower grade, that is 1, or lesions which are more than 2 centimeters, or if there is evidence of metastatic disease. If there was any history of any other malignancies also, they have excluded except a few. And patients who have had previously neoadjuvant chemotherapy or pregnant women, they have excluded. So the inclusion criteria and the exclusion criteria is fairly reasonable, and it is our patient fits into this criteria. Second question was the assignment of participants to the intervention randomized. So they were randomized into 1:1, one to the intervention arm, which is simple hysterectomy, and the other to radical hysterectomy. So it was done by a web-based password-operated electronic data capture system. So they have, one line they had mentioned was they have done this with the use of minimization method after stratification. So basically after randomizing, they have randomized and stratified for all these various parameters, such as the participating group, if they are intending to do a lymph node, sentinel lymph node mapping, age, histological type and grade, so that both the arms are fairly matched.
So this stratification is important because suppose you're doing a small randomized trial in your fact department. Oh, you have 100 in each arm. Now basically everything should be equal. 100 is not such a big number. By chance, let's go to the previous one. By chance, no, the histology might be slightly more in one group, one slightly different in another group. Then the trial is, oh, you can't do anything. And then, no, okay, then all people with this histology will be separately randomized. All people with that histology is separately randomized. It's called stratified randomization. If you have too many groups, it becomes unmanageable trial. If a very important variables in a small trial, maybe 2 or 3 groups you can sub-stratify. It's called stratified randomization.
Were all the participants who entered the study accounted for at its conclusion? The loss to follow-up and exclusions were accounted. They have done both an intention to treat and a per protocol analysis. The study was not stopped early. This is the consort diagram. So they have done the study in 12 countries. India was not included. The Asian countries they have included are China and Korea. Otherwise, they have done it across 130 centers. So they've included a total of 700 patients. It was so out of the 700, they have randomized 350 to the intervention arm and 350 to the control arm. So for an intention to treat analysis, they've included all the patients randomized in both the arms for the analysis. However, in our intention to treat analysis, in the intervention arm, 14 patients had to be excluded because either they did not receive the surgery or they had to cross over to the other side. But 2 patients from the other side came over to this side. So they had a total of 338 patients, of which 21 were excluded because after the surgery, they found that they had extensive disease. So in the end, they were left with 317 patients in per protocol analysis in the intervention group. It was similar in the control group also, where 7 patients crossed over to the other side and they were left with 312 patients on the control group.
So that is called crossover or contamination. It should not have happened, but it happens. In real life, you can't prevent, you do multi-center trials. Someone say, I don't want a simple, I want radical. You can't tell the patient. He has his right to refuse and withdraw consent. So usually those people we call as failures in that arm. So the 2 who received simple hysterectomy should have been counted in intention to treat analyzed as failure of this arm. And the 7 who had radical, who were supposed to have simple, would say failure of that arm. That's how you analyze intention to treat. Per protocol is okay, what you actually had is what you had. Okay.
Should it be crossed or should it be excluded?
In intention to treat, we put the failure of that arm. We have to account for them somewhere. So we'll keep the denominator as 350 in intention to treat, but that 7 will be as part of the denominator. The numerator will say they failed. They had a recurrence. What is that? That's the intention. Okay.
Sample size calculation. So they calculated sample size of 700 patients to provide a 85% power to the study with a predetermined non-inferiority margin of 4%. So they have taken a alpha error of 5% and assuming based on the previous study that 4% is the recurrence rate in both the arms. Were the participants blinded to the intervention? It is a surgical trial, so it is very difficult to blind. So both the patients and the surgeons were not blinded. Regarding the outcome assessors, it was not mentioned if they were blinded. Were the study groups similar at the start of the randomization? So the baseline characteristics were more predominantly well matched. So they have included patients across various races, of which 6% in the intervention group and around 5% in the control group were Asians. The mean age of our patients was 42 to 45 years of age. They all have a fairly good ECOG status at presentation, at randomization, 96 and 95%. Histological type, the most common histological type was a squamous cell carcinoma, and the histological grade was grade 2. Most of them belong to the 1B class of FIGO staging, part of our inclusion criteria. One of the few things that they had not included in this baseline characteristics was the prevalence of HPV infection, which predisposes many patients to develop carcinoma cervix, and many other risk factors like prolonged contraceptive use. Other risk factors were not accounted for, but because it is a well randomized study, we are hoping that it is also randomized equally in both the arms. Apart from the experimental intervention, did each group receive the same level of care? So, besides the intervention, there was no other changes in the both the arms, and follow-up was the same in both the arms. This is the study protocol. So both of them got this pelvic lymph node dissection. Only difference is that patients on this side had the control arm had radical hysterectomy versus the other side had simple hysterectomy. So, before we go on to the results, we would like to see the validity of our study. The study population was well defined, the outcomes were clearly defined, randomization was done adequately, allocation concealment was also done. However, blinding could not be done in the study. They have done both an intention to treat and a per protocol analysis, and the baseline characteristics were predominantly well
Who
known.
could have been blinded?
The outcome assessors.
It's very important in a non-blinded trial. As if it's possible, outcome assessment blinding should be done. So the surgeon or the gynecologist or the oncologist who determine the outcome, they need not be told. But sometimes it's not possible. In the moment they see the patient, they may quickly realize it's a radical or simple hysterectomy. In which case it's not possible. So better to say it's open label. But if it was possible to blind the outcome, then we should say outcome assessment blind. So any trial which is open label, as far as possible, you must do outcome assessment blind. Okay.
Going on to the results, our primary outcome was to see the pelvic recurrence at the end of 3 years. So here we see in our intervention arm, the simple hysterectomy, the pelvic recurrence was 2.52, and in the control arm it was 2.17. So the absolute difference was 0.35% with the 90% confidence interval of minus 1.6 to 2.3. So at the end of 3 years, they have seen that here in the radical hysterectomy it was 2.17, and in the intervention arm it was 2.52. So one thing we have to document here is that they've used a 90% confidence interval instead of a 95%, which is what we assumed when we calculated our sample size. This is the stratified results of our primary outcome, which is to see the pelvic recurrence at 3 years. Here we see so the previous one was based on an intention to treat, so they've included 350 patients. Here we see in the per protocol analysis, it was 2.76 in the intervention group and 2.34 in the control group, with a difference of 0.42. So what we have to understand here is initially we assumed we determined the non-inferiority margin of 4%. So here the upper limit of our confidence interval 2.32 and 2.57 still do not cross the 4%. So we can come to a conclusion that it is though it is inferior, we have proven that it is a non-inferior to the simple hysterectomy is non-inferior to radical hysterectomy.
Is it equivalent?
No, sir, it is crossed the.
The equivalent, that dot would have been on that line, and both arms would have been on. It would have been here.
So this is the line of margin of equivalence. So it is not 0.
So the 0 would have been somewhere
Somewhere
here.
here.
Then you'd have found it like that. So it is not equivalent and clearly it's not superior either. So we can conclude both. Okay.
The other secondary outcomes that they have seen is invasion of lymphovascular space. These are the other outcomes that they have assessed for. Positive notes at the end of your pathological specimen, residual disease. So most of it was little bit higher on our simple hysterectomy set.
Side effects?
Okay. Before that, sir, was the precision of the estimate of the intervention and treatment effect reported? Confidence interval was reported for all our outcomes. Do the benefits of the experimental intervention outweigh the harms and costs? So they have assessed for the safety outcomes. Here we see the intraoperative injury was slightly more in our intervention group than in our control group. But the only difference was the bladder involvement was less as compared to the intervention group. Other side effects such as urinary incontinence, urinary retention, and pelvic pain was statistically significantly less in our intervention group as compared to our control group. So this went on to be present in the patients even after 4 weeks after the surgery. So urinary incontinence and retention was a significant side effect in patients with radical hysterectomy even 4 weeks after the surgery. So if we were to calculate the number needed to treat, so in the simple hysterectomy arm, the event rate was 2.5. In the radical hysterectomy, it was 2.17 with an absolute risk reduction of 0.35. So the number needed to treat was 285. So how does this interpret? So if we were to treat 285 patients with simple hysterectomy, we can expect an event of pelvic recurrence. So if we were to assume the best case scenario, which is the upper end, which is the lower end of our confidence interval, we would get a number needed to treat of 62 patients. So which would mean that we need to treat 62 patients with simple hysterectomy to prevent one recurrence. If we were to assume a worst case scenario, we take the upper end of our confidence interval, where we'll have a number needed to treat of 43. So that will translate to, if we treat 43 patients, we can expect one pelvic recurrence. Can this result be applied to my local population? I felt the Indian population was not adequately represented in the study, and various risk factors which is very highly prevalent in our population was not considered in this study. Would the experimental intervention provide a greater value to the patients in my care as compared to the existing treatment? The study is very well done, so I would say yes.
No, go back. The question is resources. Is it cheaper to do a simple hysterectomy than radical hysterectomy?
Yes.
So this is a intervention where the new intervention is cheaper than the existing intervention. Is it better than the current intervention?
It is not inferior, sir.
So now let's just have some fun. Let us see that this is costlier, this is cheaper. This is better, this is worse. So where does our treatment lie in this?
Yes, sir.
So it is slightly worse but cheaper. Which of these quadrants would you like to be in? Let's ask Dolly. So this is the best arm. This is called the new treatment dominates the existing treatment. It is cheaper and better. Would you like to be here? So this is a terrible arm to be in. The new treatment is dominated by the existing treatment. Most treatments in life, most say infliximab versus corticosteroid, it will be better than corticosteroid, but costlier. So it will be somewhere in this quadrant. So this quadrant, how do we decide? We have to make a decision. How much better for how much cost? So Christina, would you prefer something here or would you prefer something here?
Yes.
Why?
Cost is reasonable.
For a little cost, we are getting much benefit. Okay, Bennett. What is this quadrant? Worse and cheaper. Would you automatically not do? It depends. So, John, Would you prefer something here or prefer something here? This one? It's much cheaper, but only slightly worse. Whereas this is much worse for a little loss of cost. So now we must make a decision for this radical versus simple hysterectomy. Which quadrant is it?
It is this quadrant, sir.
It's in this quadrant. Now you must make a decision how much resources I am saving for something slightly worse and much less side effects.
Yes.
Okay, so now with that, you're not going to increase your resources. You're not going to take money from something else to do simple hysterectomy. In fact, you'll save money by doing simple hysterectomy, but you're going to have some little bit more recurrence, which was within the non-inferiority margin. Okay, now tell me the answer to your last question.
Would I?
The next one. Tell a story. Yes.
Yes, sir. So, what would I advise my patient? So, because she had brought up this scenario where she wants lesser side effects, I would present her with the results of this study. But I would also explain to her that it was not, our patients were not represented in the study. So, whether it is applicable to us, it will only be an extrapolation. So, I would explain that to her, and I would leave it to the patient to decide, sir.
Okay, let's take a vote. How many of you will advise a patient to have simple hysterectomy versus radical hysterectomy based on this study? An Indian patient. How many of you will say yes? How many will say no? So, at the end of the day, how many are not sure? So that's how decisions are actually made. When you are very sure, if all of us have voted yes, then we strongly advise. We think that based on this trial, all Indians should have only simple hysterectomy. If we are not, if we are totally unconvinced, then we tell the patient, see, we are not very sure. But would you wait for 5 years for a trial in India before advising any patient?
No, sir.
So we can't also do that. We can't say every trial has to be repeated in India. Of course, there would be any Asians, Indians, and wherever this country was, and then genetically, racially, all would be different. So sometimes you have to take evidence from other places, and we have to make an evidence-informed decision. So evidence is there. We can meet some of our gynae-onc surgeons. What has been your experience? So that's a clinician's experience. The evidence is this trial, and then finally ask the patient. No, your patient seemed to absolutely not want urinary symptoms and all. So we have to ask, what do you prefer? She may go for a simple hysterectomy. We don't know. We have to assume. Any questions? Yes. So there's no difference. That's all right. So the thing that Kaplan-Meier curve, we are looking at the outcome at 3 years. But actually, statistically, there's no difference because once the curve starts crossing, there's no difference. But we're just trying to interpret the non-inferiority at 3 years. We said 4% difference will be considered. This is well within the 4%. Still, the radical is better, but it's not 4% better. It's only 2% better. So we'll say it's non-inferior. Or the simple is non-inferior. So truly there's no difference between the two.